This video demonstrates laparoscopic excision of jejunal GIST. The patient, a 50-year-old male, presented with abdominal discomfort, on and off abdominal pain. On evaluation, found to have 4 centimeter size, 4 by 4 centimeter size GIST, which is located 20 to 25 centimeter distal to DJ flexure. So this is the GIST after going with uh, diagnostic laparoscopy. I found that the GIST is located, it's a fairly exophytic GIST located in the um, antimesenteric border of jejunum, which is around 25 centimeter away from DJ flexure, and it's very vascular mass. You can see the uh, thick vessels are getting blood supply from the mesenteric blood vessels. So the feeding is from the mesenteric blood supply. You can see the thick vessels, maybe because of the neovascularization, and it's a vascular mass. So decided to do a segmental resection and intracorporeal anastomosis. So using harmonic shears, taking a segment, a 5 centimeter segment of jejunum, keeping the tumor at the center. So dividing the mesentery close to the bowel, and using 60 GI stapler, endoscopic GI stapler, blue cartridge. You can see one stapler fired at the proximal and another at the distal margin. So after firing, there was no bleeding from the divided bowel segment. So here a second stapler was fired and the segment is detached from the rest of the bowel. Now the only thing is attached is the mesenteric part, which is getting the blood supply, from where the tumor is getting the blood supply. So using harmonic shears, gradually in the slow mode, I was able to divide the mesentery. Since it's around 4 centimeter mass, and looks like a low grade gist only. So 5 centimeter bowel segment was good enough, along with the 1 centimeter margin of the mesentery. So now you can see the divided segments, and there is no bleeding from the divided mesenteric margin. Now I will be doing the side to side jejunal anastomosis. This was a stay suture that I have taken using a 20 PDA suture. So after taking the stay suture, I will be holding this. The assistant surgeon will be holding this stay suture, so that I can do the intracorporeal anastomosis, stapled anastomosis nicely. This will be a isoperistaltic side to side anastomosis. This is the distal segment of the bowel. So there's enterotomy was done using hook with cutting energy. Once you can see the inside of the bowel, you confirm that the whole thickness of the bowel is punctured, and this is the proximal segment of the bowel. So another enterotomy was done in this segment, and using harmonic shear, the enterotomy was little bit enlarged to help manipulate the stapled tip of the stapler. So now you can see the mucosa of the jejunum from both the enterotomy site. And now again 60 blue cartridge was introduced. Endoscopic GI stapler, 60 millimeter blue cartridge is introduced, and uh, equal length of bowel was taken into the stapler. Around 4 centimeter staple segment was taken into the stapler, and it was fired here. And after waiting for 1 minute, the stapler was fired, and after removal of the stapler, the stapled margin was checked inside. If there was any bleeding or something, there was no bleeding, it was absolutely dry. So I decided to go ahead with closure of the enterotomy. Here again, using the 20 PDA suture, first bite was kept on the posterior layer of the staple line, and then gradually from posterior aspect, the in a continuous manner, the suture was and the enterotomy site was closed in a continuous suturing manner. While taking the bites, it was kept in mind that more amount of serosa was taken and less amount of mucosa. So this anastomosis require a good laparoscopic surgical suturing, laparoscopic surgical suturing skill. And if you have this laparoscopic suturing skill, you can do this kind of operation with very comfortably. And the postoperative recovery, in the postoperative recovery period, there will be early return of bowel function, and you can allow diet to the patient in the early in the postoperative period, and patient overall postoperative recovery is faster than the extracorporeal anastomosis. And it has been studied and seen that intracorporeal anastomosis will help in early return of bowel function. So my preferred technique is to do intracorporeal suturing, and with minimal gut handling, and that will actually help in postoperative early return of bowel function. So learning laparoscopic suturing is very essential, and the young surgeons who are watching this video, so laparoscopic suturing uh, should be one of the skill that you should have in your armamentarium. So now you can see after starting from one end, and where I have reached to the other end, where I am now putting a final knot to close the enterotomy site. You can see the enterotomy site is nicely closed, and the serosa to serosa approximation has been done. Although I have kept few more bites, few more interrupted seromuscular bites to ensure the proper apposition of the jejunal loops. So this is to double secure the anastomosis. So at the gap of 1 to 1.5 centimeter, I have kept few more interrupted bites with the same suture 20 PDS. So this patient did well in the postoperative period. After the operation took around 90 minutes time, and the postoperative period was uneventful. Patient was mobilized after 4 hours, and Riles tube was removed on the first postoperative day, and liquid diet was allowed. On postoperative day 2, he passed stool, liquid stool, and full liquid diet was allowed on postoperative day 2. On day 3, soft diet was allowed, and discharge on postoperative day 3. And the final biopsy report came out to be low grade GIST, and he is under regular follow up and without any adjuvant treatment requirement. So after closure of the enterotomy, the mesenteric window was closed. The jejunal mesenteric window was closed to prevent postoperative internal hernia formation, and that will also help to keep the bowel segments in apposition, and will reduce the tension on the bowel on the anastomosis site. So sometimes during suturing, the suture length becomes small, and you can do certain maneuvers and certain help of your assistant to do the suturing nicely. So that completes the anastomosis, side to side intercorporeal anastomosis, and it was covered with the greater momentum. And finally the specimen, which was kept in a specimen bag, and by enlarging the port of 12 millimeter, where I kept the stapler, through that port a little bit of enlargement, dilatation of the port, I take out the specimen. This is the final look of the after the finishing of the operation, and this is the specimen. Thank you so much for watching this video.